We are going to talk about post-exertional malaise today. And this is really a critical topic when we talk about fatiguing illnesses like ME/CFS and like post-acute sequelae of COVID. So the original definition for PEM comes from the 2015 Institute of Medicine criteria for the diagnosis of ME/CFS. And they define it as an inability to recover normally following physical, cognitive, or emotional exertion, and that inability to recover results in a level of fatigue. And it's not just fatigue, but it's a sense that is impairing function. So it's profound and devastating and longer lasting than we see in any other fatiguing illnesses, whether that be cancer or other autoimmune illnesses. This fatigue is often accompanied by a very significant loss in stamina, reduction in functional capacity, and augmented symptoms of the underlying illness, whether it be long COVID or ME/CFS. So you can have worsening dysfunction of the autonomic nervous system, worsened efficiency metabolically. You're not generating as much ATP or energy at the cellular level as you would in your baseline illness state, dysfunction of the immune system, over and under activation of different parts, and perturbations of the hypothalamic pituitary axis, which controls our endocrine systems. Some of the augmented symptoms in post-exertional malaise that we'll see commonly are flu-like symptoms. So people will feel fevers, sore throats, arthralgias and myalgias, so that's muscle aches and joint pains. Cognitive symptoms may become worse. They describe a sense of brain fog, difficulty finding the right words to use, inability to concentrate or focus. People may be exhausted and yet unable to sleep. They can have headaches or worsening of a baseline headache, sensitivities to light, to sound, to multiple sensory inputs all at once, and orthostatic intolerance, which essentially defines an inability to be functioning as well upright as when you are laying down. So it is not uncommon for people who are experiencing PEM to feel like they can't even get out of bed on those days, although the experience can vary widely from case to case. Many people during post-exertional malaise will struggle to complete basic activities of daily living. It's hard to get up and get dressed. It may be hard to go to the bathroom. It's very hard to take a shower. It's a struggle to even throw in a healthy choice into the microwave to eat, to prepare food. They're definitely not cooking. And I've had people say, you know, this is different than I am in so much pain I can't get out of bed. It's literally something else, something more oppressive, something like gravity's heavy. And they've said, you know, if there was a fire in the house, I'm not 100% sure I'd be able to make it out in time. Or if I did, I'd collapse on the lawn, not far from the heat, but I wouldn't be, you know, 2 doors down watching the house burn down. It's that hard sometimes to remove yourself from the situation because of the lack of energy. And you know, to that point, what are the triggers of PEM, or post-exertional malaise? So certainly exercise is a huge trigger of PEM when people are dealing with one of these illnesses. Orthostatic stress means spending more time upright. Now I'm sitting here at a desk chair with my feet on the floor. We consider that upright time. If my legs were elevated, if I was in a recliner, if I was laying down, that's not upright time. But just being upright as opposed to laying down during the exact same activity can be a trigger for post-exertional malaise. Cognitive or mental activities, reading, having a social discussion with improvisational conversation, those can be more utilizing of ATP than we realize. Stressors in our surrounding environment, bright lights, loud sounds, multiple visual inputs at once. So if someone's on the highway and there's a lot of cars going past, just processing all of that, again, is a very demanding process from an ATP perspective, and even chemical exposures. And then emotional responses can also trigger post-exertional malaise. And that doesn't have to only be negative emotions. It can be Christmas morning, I'm excited to open presents. Anything that utilizes energy can be a trigger for post-exertional malaise. So some other examples of that, especially in people who are severely ill, and again, there's a wide variation. Some people seem relatively functional on the surface. Other people barely leave their house, right? And or don't. But in our more severely ill patients, things like reading a book, using a computer, just having a conversation for more than 15 minutes that's not, hey, what do you want for dinner? Something that's a little more in depth. Taking a shower, even sitting up to eat a meal rather than eating a meal in bed, those can be triggers for post-exertional malaise in our most ill patients. So there are several analogies that we use to try to help patients understand how PEM is occurring, because it's not always clear exactly why it's happening on any given day to people, especially at first. So one thing that we'll say is think of PEM as debt. Every day you have $1 to spend on energy exertion. And maybe one day you're feeling good. It's been the first time you felt good in 6 days, and so you got to catch up on things, right? You have a lot to do. You're interested in being involved in your life. And so you go on a spending spree and you spend $10 in one day, and that'll catch up with you real quick. You're likely to have post-exertional malaise, not in the moment, but usually with a delay of 12 to 24 hours the following day is when those symptoms of post-exertional malaise may really kick in. But maybe more confusing and more difficult for patients is if you have a few good days in a row, and maybe you're spending $1.25 or even $1.05 every day for several days, and you're doing fine, and you don't feel bad, and all of a sudden the debt collector comes and you have to pay that back with interest. So you had a great work week, Monday through Friday. Saturday you were feeling good. Halfway through the day, Sunday you wake up and can't get out of bed, and it's sometimes harder to pinpoint exactly how you got there when it's that second scenario. So here I'm talking about cardiopulmonary exercise testing. This is really to say, look, it's one thing to describe a clinical scenario, but is this really an actual pathophysiological process? Is this something that people think, it's in their head, it's their experience of their symptoms? This is something that has been really used as proof, essentially, scientific proof for the existence of post-exertional malaise. So CPET, or cardiopulmonary exercise testing, is a validated tool for assessment of functional capacity among healthy people and in people with debilitating and fatiguing illnesses. It's been used and validated across all kinds of illnesses. And it looks at the contributions of metabolic, cardiovascular, respiratory, and muscular inputs to the generation of energy. So what's really interesting with ME/CFS and long COVID patients is when you do serial 2-day CPET testing. You do an exercise challenge one day, and then you do it again the second day. This is a reliable, reproducible, and accurate measure of PEM. So generally, if you take healthy people, or you take people with fatiguing illnesses like heart failure, COPD, end-stage renal disease, pulmonary hypertension, cystic fibrosis, multiple sclerosis, if you do this cardiopulmonary exercise testing, they may have reduced capacity on day one, but on day two, their capacity is similar to that of day one. There's very little variability or change. However, with ME/CFS patients, with long COVID patients, they are unique in that they cannot reproduce the same outcome measures on the second day of testing after the first day of testing, so long as those are 2 days serially in a row. So this test is particularly effective for measuring peak oxygen consumption, or what we call VO2 peak or VO2 max during exercise. This is again a validated, well-recognized indicator of functional capacity and is a surrogate measure for the maximum energy available for work. And what we see in our in ME/CFS studies is that people have relatively similar initial VO2 peak on the first day of cardiopulmonary exercise testing. They may be a little deconditioned compared to healthy controls or people with those other illnesses that we mentioned, but it's that second day where they cannot reproduce the same VO2 peak or VO2 max. They can't reach their ventilatory threshold, achieve peak workload, and they're unable to duplicate their workload at the ventilatory threshold as compared to day one. We don't actually do cardiopulmonary exercise testing very often anymore because inducing PEM is actually creating harm. But this at one point was used as a validated tool to help people with these disabling illnesses receive disability benefits. But we don't feel like this is necessary in day-to-day clinical practice to make a diagnosis of post-exertional malaise. A lot of people with ME/CFS and post-acute sequelae of COVID, they have dysfunction of their autonomic nervous system. There are people that have dysfunction of the autonomic nervous system that don't have post-exertional malaise, this defining characteristic of these illnesses, right? And there's good evidence in those people without PEM that exercise over time does improve their quality of life and their management of symptoms. The difference is when PEM comes into play, which is why screening for it, understanding it, is so important. And when there is post-exertional malaise, if you exercise and induce post-exertional malaise, you are absolutely setting yourself back and doing harm. And so the key, really from our perspective, is that exercise, in theory, is still okay so long as you don't trigger PEM. But like we're talking about with these patients, if your threshold for PEM is too low for exercise, then it's too low, and exercise is not helpful. And I think that kind of segues back to this cardiopulmonary exercise testing, which again was really meant to just show that we know something is physiologically changing during this time. It is not just something we're experiencing in our central nervous system in our brain. It really is a failure in cellular metabolism, and we are in a different metabolic state during post-exertional malaise. So if you consider the impact of reduced cellular metabolism and reduced production of ATP in skeletal muscle, cardiac muscle, vascular smooth muscle, GI smooth muscle, the way you're using energy in the gray and white matter of your peripheral nervous system, of your central nervous system, the diverse presentation of all the symptoms people can experience that worsen during PEM makes a lot more sense, I think. So this is really to get into what you were asking, but what are the clinical implications of post-exertional malaise? It's probably the most debilitating and miserable aspect of ME/CFS and long COVID. It's long been recognized by clinical providers who treat ME/CFS that continued and repeated episodes of post-exertional malaise within any one individual, these are associated with a worsened long-term functional prognosis. If you keep crashing, if you keep having post-exertional malaise, your good days get worse as well, and then you still have your bad days. So when patients choose to or are spurred to push through their symptoms, fight through it, you can do better, to the point of inducing PEM, they can experience particularly severe or prolonged episodes of post-exertional malaise that reset their baseline function to where their bad days, their PEM days, are now their good days. And then when they have PEM beyond that, it's even worse. So do not push through, respect the symptoms. And that's not a message we get in a lot of our other illnesses, unfortunately. So one analogy I like to use for post-exertional malaise is that it's an injury. It's really like a neurophysiological response taking place during post-exertional malaise, and this injury can accrue over time, leaving a permanently altered function or injury or change neurologically when you exceed some threshold of frequency or intensity of these biological processes. And the opposite, of course, of PEM, it's pacing, right? We have to, when our body is telling us that we can't do it anymore, there's not available energy, we actually have to listen to it to avoid this repeated injury, to avoid having a worsened long-term prognosis, to actually making ourselves worse. So unfortunately, there is nothing definitive that speeds up recovery from post-exertional malaise. Hey, doc, I'm in PEM, what do I do? Well, you kind of give into it to a degree and not fight it, not push through it, let it run its course, because it's actually going to ultimately be shorter and less profound if you just let it run its course. If you try to push through it, you're utilizing energy you don't have, you're only prolonging it, and that's really, really difficult. Easy for me to say, not easy to do in practice. So forced, continued, repeated exertional exercise to combat an underlying decompensated state, while seemingly logical, actually only promotes worsened long-term functional outcomes. Graded exercise therapy, which is used in some autonomic dysfunction, is absolutely harmful to people with PEM. A patient doesn't manage ME/CFS or post-acute sequelae of COVID on the whole by fighting harder, but instead by being smarter and employing discipline, calculated intelligence, to minimize the intensity and duration of PEM or to avoid PEM altogether. So no graded exercise therapy for those with PEM when it's present. Instead, here's what patients should do, what we tell people. And these are just some tools that we use for people to help them work through this. So remember that cognitive exertion, even subconscious processing of sensory inputs or emotional exertion, are as damaging as physical exertion. We tell people to think about their energy envelope, to think about where they are in their battery, and to think about taking frequent restorative breaks to recharge that battery. So what do we actually do to manage PEM? How do we avoid this injury, this harm, this possible setback in our day-to-day, but also long-term in our function? And the key is to be able to pace, to stay within that energy envelope, to never let that battery get to 0%. That has to be paramount. And I tell people I have all kinds of tools for helping to manage ME/CFS and long COVID, but if you don't pace, if you keep having post-exertional malaise, all of that is null and void. This is the cornerstone on which we have to build clinical care, and it's avoiding post-exertional malaise. So when it comes to managing PEM, people will call me and say, hey, I'm in a crash, Dr. Yellman, what do I do? And the problem is there's nothing definitive that we can do during post-exertional malaise to make you better, other than to not make it worse, right? Keep fighting, keep pushing through. That's only going to prolong that reduced metabolic state. And so you almost have to give in and accept it and just say, I have to let this run its course. I have to not be upset at myself for getting PEM. It's hard to avoid. It's not my fault. I'm just going to relax and get this over sooner. And it is over sooner if you can do that. It's much easier said than done, but people who are good at that end up getting better much quicker from PEM. So as you can see here, graded exercise therapy, while it may be good for people with dysautonomia without post-exertional malaise, it certainly isn't, because it almost universally causes PEM in people with ME/CFS and post-acute sequelae of COVID. So forcing continued repeated exertional exercise because people are decompensated or deconditioned, it makes logical sense, but it honestly doesn't when you really think about how post-exertional malaise works, and it does harm. We never recommend that. So you don't manage ME/CFS or long COVID on the whole by fighting harder. Instead, you have to be disciplined and fight smarter with calculated intelligence to minimize the intensity and duration of PEM or avoid PEM altogether. So there are a lot of different strategies I talk through with patients to help, and this is really just to get people thinking about it. This is a skill that develops over time, as I'm sure you've experienced, Chimére. You get better at it as you start to learn and have setbacks. But I try to tell people, remember, it's not just how much time upright did you spend the day before, how much exercise did you do, how much did you do cognitively, right? And that can be subconscious processing. You know, sitting in front of a window and staring out, but there's a ton of stuff going on. You're processing all this sensory input. That is still using a lot of energy on the cellular level. Emotional exertion, as we touched on when you were engaged, right? That is going to, not your fault, but is going to utilize a bunch more ATP than you would otherwise, right? So it's as damaging as physical exertion. So don't forget the impact of what your mind is doing and processing, whether it's a conscious or subconscious process. It's really important to think about that battery or that energy envelope and where you are in that envelope. And it's the entire reason that frequent restorative breaks are necessary. It's not the same as being completely back to normal, but it's way better than 27, 28 bad days per month. So using timers to remind you, I just have to take a break, I just have to stop even though I still feel good, can be a strategy that's really helpful, especially early on. Modifying activities just so that you're doing less physiological stress. It's more work to be standing than sitting. It's more work to be sitting with your feet on the floor than reclined or laying down or having your legs elevated. So modify activities just a little bit. That can go a long way. This is sort of for the clinicians, but also for patients too. Just kind of a thought experiment, and that is really, I've seen a lot of patients where I may implement something to, pharmacologically to expand someone's energy envelope. Hey, I can go a little farther without hitting post-exertional malaise. This is great. Well, what are people going to do? They start feeling better, and then they want to make up for lost time. And they may go just a little far. They don't know where their limits are. The battery has changed. It's an ever-moving target. What do you do with that? And then all of a sudden you're in PEM. So by the time they come back to me as the clinician, I gave them this medicine, did it help? Well, actually, they seem worse right now. The reality is it helped, but then they went a little too far and got into post-exertional malaise. So it can both help and hurt people when we move that line. And it's just something to remember and to always be thinking about when assessing any intervention in the context of ME/CFS. It's always seen through that lens, that kaleidoscope of post-exertional malaise. And I just want to also mention that, one challenge I will give patients, and sometimes I don't do this until we've seen that they're better at understanding triggers for PEM, they're starting to get better at, what do I do to avoid it? They still have moments where, hey, I have to go to this wedding, I know I'm going to have PEM, but it's just too important to miss. We allow for those things, right? We try to plan ahead and rest before, we try to have recovery after. You still have to live life to some degree. But I'll issue patients a challenge at some point when they have a little better handle on things and say, you know what, I challenge you to go 2-3 months without PEM at all. and without any other clinical intervention, just that period of time of healing without injury, people's energy envelope will expand, their functional capacity, their cognitive capacity improves. What has helped people is things like wearable devices, monitoring their heart rate, for example. And it's not that heart rate is pathologic, but when it elevates to a certain level, it tells you your body is under physiological stress. So I have patients who may be doing 10 minutes of gentle yoga on their back, and they'll do it every other day for 3 weeks, and they've always been able to get through the 10 minutes, and then one day their heart rate's spiking way higher than it normally does 2 minutes in. And what, I got to do my 10 minutes? Well, no, there's something that we don't recognize about that day where your body is more physiologically stressed than it was other days. We may not know what that is. Maybe you were exposed to a virus. Maybe there was an emotional thing from the day before that you didn't quite appreciate. Maybe sleep was just not as restorative that night. But when your body's heart rate is spiking like that, it's telling you you're under physiological stress and you just need to stop, or you need to take a break till that heart rate comes back down to what your baseline is before you restart and engage in those activities. So we're finding that a very targeted approach in that way, monitoring for feedback on how your body's doing on any given day so that you avoid PEM, gradually, slowly over time does help people. But again, not a thing we employ initially, just something down the road that is okay. So we're not anti-exercise, we're anti-PEM.
Yes, gotcha. Are there any resources that you provide or that you suggest so that patients can learn a lot more about PEM and pacing?
We've done a lot of continuing medical education products, including a Project Echo lecture on post-exertional malaise that are free and available on the Bateman Horne Center website. We're a nonprofit. We don't get any money for any of this. This is all free and available for anyone to access at any time, to share with providers, to share with family and friends. Some of it is geared towards medical professionals, but I think you can still gain quite a bit of it, knowledge from watching it. There's a little more information there on kind of the science behind PEM for providers in particular who are interested in understanding what's actually happening. And then we have, I think this is a pretty invaluable resource, this MECFS Crash Survival Guidebook on our website as well. This is for patients in PEM. We said there's not that much you can do on a pharmacological basis, but there's a lot you can do within yourself, within your home, with your family, with your friends. There's some guidance for medical providers in here on how to get through this and then avoid the next episode. So we've gotten really good feedback on that Crash Survival Guidebook, and I would encourage everyone to look that up and print it off and keep it with them.